This meeting is being recorded.
Good evening to all of our friends. Good evening to everyone on Facebook, everyone around the world, all our partners in public service, all our partners serving their communities around the world. We want to welcome you to another segment of AfriH. AfriH is an acronym for Africans for the Restoration of Ethics in Government. We are a nonpartisan organization that harnesses the expertise of professional Africans and global partners around the world to discuss issues significant to Africa and her well-being. We are a solution-driven organization. That means we only discuss solutions to problems we see impacting Africa, and we bring about ideas how those problems can be mitigated for the well-being of Africa and the African people. Tonight is another segment that we have been looking forward to. We have the honor to be with us of Reverend Dr. Boakai Paasewe. He is a Liberian who lives here in the United States of America in the state of Wisconsin. Just a little bit information about Dr. Paasewe. He got his BSc in chemistry and a Doctor of Medicine from the University of Liberia. He also obtained a diploma in public health from Witwatersrand Graduate School of Public Development in South Africa. He also served as a physician at the John F. Kennedy Memorial Hospital, the only teaching hospital in Liberia. And he held different positions in the health sector in Liberia, including program director for the Health and Water and Sanitation Program for the Liberian Red Cross. He has traveled extensively, in that position as a program director for the Red Cross in Liberia. He was also a member of the West African Disease Surveillance Team of the International Federation of Red Cross Societies. He pursued in the United States, he pursued his MBA concentration in health service management from the Keller Graduate School of Management. He has also worked with the Clinton Health Access Initiative, previously the Clinton Foundation, in 2010, that allowed him to travel back to Liberia, where he served as a consultant to the decentralization initiative of the Liberian government, specifically the Boakai County Decentralization Project. Dr. Paasewe is married to his wife, Darlene. They have 6 children. They have been blessed with 6 children. He's also currently the pastor of Word of Hope Community Church in Milwaukee, Wisconsin, and a full-time faculty in the medical assisting program and course chair of the Health Serve Management program of Brian Stratton College in Milwaukee, Wisconsin. Dr. Paasewe, that's a long list.
Yes. Thanks a lot, Dr. Reese. Thanks. Dr. Rex, thanks a lot. Thanks a lot.
Thank you. Welcome to AfriH. Welcome to AfriH.
Thank you so much for the opportunity. I really appreciate it. Thank you very much.
Yeah, we got a lot to talk about tonight, and welcome to all our attendees tonight. We entitled our segment "Building Sustainable Healthcare in Africa." Building sustainable healthcare in Africa. I think the key word is the word sustainable for me. Sustainable.
I agree with that.
To start our segment, I will say this. I kind of did a little bit of research. And it showed that about 72% of all deaths in Africa are from communicable diseases such as HIV/AIDS, tuberculosis, malaria, respiratory infections, complications from pregnancies and childbirth. But around the world, other World Health Organization regions only have about 27%. The research also showed that healthcare in sub-Saharan Africa remains the worst in the world, with few countries being able to spend, and it was interesting, few countries being able to spend between $34 and $40 per year per person, which is considered just a minimum for basic healthcare. As I look at these stats, that as an African, it was troubling to me. It was troubling to me. And I will ask you this question, why are our people dying from these communicable diseases? I mean, does it have something to do with policy? Does it have something to do with bureaucracy? Does it have to do with implementation, logistics? personnel shortage. I mean, all of the above. What's your view, Doc, when you look at these stats as a health professional? You know, where can we say the problem starts?
Thank you, Dr. Rich. Having seen both sides of medicine, right? Having served in the clinical medicine, clinical aspect, and also have spent a lot of time in preventative healthcare. Even though the problem is multifactorial, but the underlying thing in sub-Saharan Africa is poverty. Poverty is the underlying, and that's why if you look at the millennial goal while working in Liberia, the millennial goal was about reduction in poverty. Now you will see countries that have made progress in those stats in the sub-Saharan Africa are those countries who, to some extent, have been able to reduce that poverty level. So underlying that is poverty. So if Africa must address those problems, they must really focus on poverty reduction, which was part of the millennial goal for most countries. Now, having said that, and I want to say that any health system, there are three pillars. When you're addressing health system, your policies that you make must address. And I want to agree, policy is one. But underneath that is poverty. But policy should address three things. In any health system, there are three pillars. One is accessibility. You got to look at where you put your health facility. It's accessibility. Two, it's affordability. Now, that brings to the question of poverty. So you have a health system there, it's accessible, but can they afford it? Can the population, the target population, can they afford to go to clinic every day? Considering how much the government is spending, right? And the next thing is quality. Those three pillars are essential in the development of any health system. So yes, so policies should address that. And I say there's not policy, but if there's policy, it's an issue of implementation, you know? And so it's multifactorial when it comes to the health system. And so if we must address that, we must address healthcare. We must look at our health system. Even in the United States, right? The health system is more curative bias. And because it is, Liberia health system is curative bias. And curative care is by far, far expensive as compared to preventative services. So yes, I mean, if we can address, if I place it in order, I would say one is poverty reduction, and next policy. The health system to be policy driven. Then come to implementation, then training and retaining of healthcare workers. Because it's one thing to train them. If you don't incentivize them, they're gonna leave.
Wow. Let's talk a little bit about prevention, because you did mention prevention. I think we all can agree that it's important to prevent people from getting sick, then to wait for them to get sick and then try to find solutions to their illnesses.
Definitely.
A lot have been talked about, prevention that we need to prioritize, and I believe you as a professional in that area, you also sound that alarm that we have to do what we can to prevent these things. And you just alluded to creating jobs that people will be able to work and buy food, eat healthy food. You also mentioned policies that will be passed that in retention, training and retention of healthcare workers, which is essential. How can government implement a policy of prevention to create a healthy nation? How can government come alongside to do that?
And that's very good. The thing is this, let me just I took some notes. Let me say here today is that we have to really sit down and begin to take what we call primary healthcare approach, which is preventative approach, right? And the reason at times governments are not keen on pushing for preventative services because you don't see results quickly. Okay, for example, somebody comes to the clinic, they have malaria, you treat them with anti-malaria for 3-4 days, you see quick results. The person is back, okay? But some preventative services requires a behavior change. And you all know it takes a while. So many times people are not keen on investing in preventative services. Government they're not willing to. So the thing is that we need to sit and realize that, okay, we don't have the money, our best bet is to use preventative services. And that comes from the issue of policies. Policies must be instituted where we say, okay, now this would be our new vehicle. You're right. And then another thing, let me tell you one thing, let me share my experience with you. And my experience when I served as the manager for the water and health team in the Liberian Red Cross, we wrote a proposal. I'm close to 1 million for the southeastern, right? So we did an assessment, went to a particular area where the incidence of diarrhea was very high diarrhea. So what we did an intervention, primary healthcare prevention. We instituted a toilet because we realized it's a drinking water, pit latrines. We brought hand pump, and we brought health education. 3 things. And then we went back after 6 months, the number of patients reporting diarrhea significantly reduced. So the 3 things we did was that you got to find out what is the source. And that's why in healthcare, I like when I work for Clinton Foundation, the issue of decentralization, I think work there, I think is the way to the future, where each county will set and write its own health plan. Because it needs varies. The needs of the population in Monrovia is quite different from the needs of the population that just being perceived for Liberia now. It's not for another part of Liberia, because some community are rural, they are disadvantaged. So the needs will vary. So what the decentralization program did, which was very good, the county health team, each county had their own health plan, which I think is very good. They manage their own budget. And donors that came to help will sit with the county health team and say, okay, and then you look at my plan and say, this is what I need. But in the past, what was happening, these donors will come and say, oh, this is what we're going to do for you. But that's not my need. I don't need that. I need a roll, farm to roll, to take my produce to the market. That's what I need. I don't need all your fancy stuff. So one way, as I say, is that government must begin to address the issue of making a policy. It's cheaper too. It requires investment. Let me tell you one thing. The government be willing to invest. Healthcare, the government be willing to invest. In terms of what? In terms of training, right? We need to and look at the doctor-patient ratio, the nurse-patient ratio. It's quite alarming in most African countries, right? So we need to improve that, and you can only do that by policy. There's an African country, I know they have a policy of sending X number. It's a policy of their healthcare workers for advanced training. That is a policy. So, but then the thing is that when they return, you have to compensate them, you have to incentivize it, right? Then we need to look at the issue of as I say, retaining these healthcare workers after they are trained. If we don't retain them, we have the issue of brain drain. People will leave, people will exit.
That's right.
To look at our education, our medical education. We need to really, let me tell you one thing, for our school, the career college approach, the lab is set up like a doctor's office. Every equipment you can think about in a doctor's office, most of them are in the clinics, in the school. So by the time the students leave, they are able to function. So it will require investment. Then the government must partner with private sector, and bring them on board and approach the healthcare from an issue of partnership, and improve the working condition. People must be able to, the working condition, so that, for example, if I'm going to a particular rural area, at least I'm be able to have a school for my kids. I'm gonna be able to have a school, but you can't send a doctor or nurse to a particular rural disadvantaged place, and they got family. Where do their children go? So it's an investment. It is an investment. So the government need to look at holistic approach to African care. And
wow, so
it's
I mean, just listening to you, that there's so many, and again, from the layman's mind, as I'm coming from per se, there's so many layers, to really fully establish just the infrastructure alone. I mean, just to, because, even though our segment of building sustainable, I mean, to sustain this thing, as you mentioned, there's just so many different infrastructure, because, you rightly said, with a medical doctor going through formal training, or a nurse, and you assigning them in rural areas where there's a high risk area, these are high risk areas, and they don't have any, infrastructure for their families. I mean, then you're absolutely right, because even, I mean, there is no clinic there that's fully equipped, and staff, to serve, that they can serve through to meet the needs of the people, then that creates a problem. So just to build the healthcare sector alone, from what you're saying, you're looking at all other sectors. I mean, you look at, the
Yes.
community and, the landscaping, you're looking at everything else. Let's talk a little bit concerning the healthcare workers, okay? Let's focus on healthcare workers and their training. In your estimation, in your experience, how will you assess the quality of training for healthcare workers, in this area? I mean, do you think is it sufficient? Should more be done to train these workers? I mean, should scholarships be available to send them somewhere else for adequate? I mean, how will you assess the present training of the healthcare workers we have in Africa? Okay, and then what it ought to be from your assessment.
Good, but before I go there, you use a keyword sustainability, right?
Yes.
So let me tell you, when we're working for a clinical foundation, they think that the NGO they will come and establish a structure, they will support the structure, but they will say free for service, right? And then all of a sudden they will just decide, say, oh, we're here for 3 years and we're fading away. And my thing was that, no, you have to put in place a sustainability plan where you have a fade away period. So, okay, right now we have the clinic, will be supporting 100%, right? For the first year. And then next year we'll reduce it to 75%. And then we sit down and we say, okay, but then where would the 25% come from? Or where would the 10% come from? And then gradually there's a fading away. But what they do honestly, they go into rural disadvantaged community. They say going for 3 years or 4 years. Okay, they have this massive structure, free for service. Okay, they got all this money, and then after 3 years, we're pulling out. But there's no sustainability plan. There's no fading away plan. You didn't sit with the community, with the government, and say, okay, look, you know what? I'm here for 3 years. Okay, and I expect my first year will be 100%. The next year will be 90%, and the government can come in with 10%. The following year will be, and that way you have a sustainability plan. But sometimes what happens is, the government, it cannot sustain it. It's because there was no fading away plan. More than that, they don't have it. No job. They go in, massive money, massive service, free for service, get the community dependent, and then they go away. Now, another thing, they don't partner with the community. And again, we had that experience. Drugs were getting missing from the community, for one of the clinics we were running, and then we decided to sit with the community and say, look, here's your clinic. So we set up a bowl, right? Clinic bowl. That's what we did. And the community took a leader that was like the chairman of the clinic board. And I tell you one time, the drugs theft went really low, because now they saw that community, that clinic as there. So we try to empower the community to community ownership. Once get the community involved, but many times, in primary healthcare, in community diagnosis, you can make the diagnosis for the community in the absence of the community, and that might really happen. These big NGOs that come there, no community diagnosis, they come and say, oh, this is what you need. No, get the community involved. Let them speak about when it comes to community diagnosis. Let the community take the lead in that community diagnosis. Let them work with you, okay? Now, talking about the training, now, as I said, I've wound a lot of caps. In Liberia at Bombing Clinic, Bombing County, I was also the chairperson of the health science division. And I was able to revitalize the nursing school there and got accredited. Yes, we're doing something to some extent, but there's still a need for an investment in terms of equipment, availability to books, availability to resources. And my thing, I tell you one thing, our students at our school, but when they leave, they can function as a medical assistant, they can function as a nurse, because the environment is so set up that some of the equipment, majority equipment, common equipments that are in doctor's office are in the school. So the students know how to operate that. There's a flow, there's a role playing. If a patient comes, what do you do? So they role play. And so by the time they leave, they can function. So yes, there's a lot of things to be done. There's a need for government to invest in health education. And again, but at the end, they need to incentivize the healthcare workers.
Wow. Wow, wow. Doc, this is heavy on our hearts. And I
It
and I
is.
think I think with someone in your capacity who's seeing hard numbers, you see these things, you've experienced it. When you were speaking, something kind of stood out to me when you mentioned the discrepancy in the ratio between the patients and the workers,
Oh
the
yes,
patient
it's
and the
terrible.
workers. Um,
Yes.
so that means now that if we begin to prioritize, go through a list of priority, then I mean high up there would be the education, of more healthcare workers, or pretty much uh, inspiring more Africans to go into this sector, to go into
Yeah.
this sector. Talk to me about, and to our audience, about the importance of the education of the healthcare worker.
Good. Now you let me take you back. You remember I said there are three pillars. If you must address the health needs of any country, you have to look at the three pillars: accessibility, affordability, and quality of care. Now, there's where quality of care is compromised, right? If you look at the ratio in Africa of, I mean, let me say
Mm,
Liberia that I can speak to because that's where I work,
yeah.
of doctors to patient is quite alarming. It's really alarming. So what it put to question is the quality of care. You look at the actual ratio of trained nurses, not those who consider themselves nurses, but really trained, certified, board certified nurses in Liberia to the number of patients, it's quite alarming. You question the quality of care. So if we must address the quality of care, we have to address policy, where we say, okay, we invest in our nurses, we invest in our allied healthcare workers, we invest in our medical doctors, okay, to improve the ratio. And you have a timeline, and say, okay, in 2000 days, we'll train 800 doctors. So we have a goal. So by 20 days, you have, okay, we'll be able to reduce the ratio to whatever the government wants. But you start with this year, with policy. 2023, we'll train this a number and this a number. But let me throw another thing to you. As I said, I work a lot. In bombing, we started one time. One thing I saw, we discussed it, I want to join, is maternal mortality rate. That's so hard, okay, right? But let me tell you what we did in bombing. Performance appraisal. And for me, Rwanda had a good success with that. Even though some people have drawback, but I think performance appraisal. And for me, I think every government official should have a performance appraisal. So what we did was this, right? So we noticed that if there was, when there was an increased facility-based delivery, the number of women dying in that community reduced significantly, right? But then we began to encourage the healthcare workers to go to the community and liaise with the traditional birth attendant. Now, the problem is traditional birth attendants, the women in the community trust them more than the clinic workers, right? Because of traditions. These women are older, these women deliver their mother, these women deliver their mother, so obviously they will go to that, those women. But in case of complications, those traditional birth attendants don't know how to do it, right? But there is this loyalty and there is this money that go to them. So we were telling the clinic workers, healthcare workers, go to the community, establish this meeting, and try and bring these women back. They would not do it, right? So we asked one of our partners, okay, look, let's come to this one clinic as a trial. Let's introduce performance based. And then I'm sorry, our dog. So we had, I'm sorry. So we had the performance based on this. Okay, we say, okay, we had indicators. One was if you can bring in X number of women from the village to do the facility-based delivery, you get this extra money. I'm telling you one thing. So then we look at, we set the indicators. We may use 5 indicators, and there's a weighted column. And so we say, okay, if you can do this, you get this extra money. That's performance appraisal, right? We'll verify this. When we verify, then you'll get extra pay. Guess what? And then when the women came, we had what we call mama baby kit. So that when the women deliver, and another reason why you see Africa is a little complicated. When the women come to deliver in the facilities, when they call hygiene care, they don't have it. So they don't want to deliver in the facility. You see, it's really complicated. You see, Africa, you can just send us all this. You have to look at the traditional practices. You have to understand that before you go about criticizing and say you want to introduce a change. You have to understand that It can be a hindrance. So then what we did, we realized, okay, because now it's embarrassing. So then we began to give what we call mama baby kit. And I tell you, when we introduce mama baby kits, where in that kit we have something for the mom, the hygiene, right? Hygiene for after delivery, what to use, something for the baby, something for the dad. I tell you one thing, from a person of work, those women with the number of facility-based delivery went increased by almost 100% in one clinic bombing. I'm telling you, it increased. But again, the NGO said they couldn't continue. They were just a pilot project to prove that it works. It works, you know. And so we had that. I don't want to introduce that. We had that success. And the thing is this: maternal mortality rate is because again it boils down to the ratio of nurses or healthcare workers to patient, the availability of facilities. Some women are in Birmingham, they had to walk in 3 days to the nearest facility to deliver. Can you imagine? Walking 3 days. So then we again, you know, before the pool fund, we say, okay, let's establish what we call a center for women, a waiting center. So we encourage women to walk, but when the near term and they are kept there. But the problem is that how do we sustain that center? Because so let's say we encourage them to come when they in that when about 30 something weeks, when they have like 2 weeks to deliver it, and they come there and they come with a traditional birth attendant, because they will not come all the women. They have this loyalty, and we tell them the women, you can take your money, you will still take your money, but you just stand by while the midwife perform the delivery. And I tell you, it works. So the traditional birth attendant, she got her money, so she was certified. It was a win-win, right? And then these women delivered to the clinic. They had the hygiene, they had something for the baby, they had something for the dad. It works. And how much does it cost? Not much. I'm saying government need to really invest in healthcare. If we prioritize and build and just build on it and build on it. Performance appraisal, for me, it works.
You know, I'm glad you mentioned that, because many times I think the issue we have and you know, it's just like, you know, training people, get enough people trained, send them there, assign them to different places, and things will be okay. But what you just said was an eye opener, that we cannot negate or neglect that there are some traditional people in those villages that have been doing these performances, whether they are equipped or not, it doesn't matter. Just that the people in the community in the villages trust them. Yep. So even though you have well-trained doctors and nurses coming, their loyalty to these traditional people that live in the village with them is still there. Yep. So you have to be able to get these traditional people on your side to bring all these women to the clinic. You know, that's I mean, it tells me that you know, when it comes to healthcare in Africa, you just cannot be one-dimensional. You have to be able to. You have to understand the villages, how the rural area operates. You know, because because what I'm hearing is that you can pay $1 billion bill, the biggest and the most equipped facility in the rural area. Those people will never trust you until that traditional person who does their services get on board with you. You know. And so the strategy that you implemented, being able to get these traditional workers, you know, to understand what you are doing and to come alongside and to give them some incentive, made them, you know, feel at ease to convince the people that they serve, yes, come to the hospital, you know, let's go to the hospital together, and they took care, and you took care of that need. And so that is crucial, because oftentimes, what you said, from the West, they have the good intention, but it just focus on, you know, okay, benefit, the people will come automatically, you know, and then so you're looking at trust building too. I mean, because if you're a stranger, they don't know you, you know, even though you have the facility, but they do not know you, they know that traditional person. So being able to have a plan in place how to befriend that traditional worker, you know, integrate them in your system, then through that, you'll be able to convince the village that, you know what, we can trust this clinic, we can trust this doctor, XYZ.
Yes. Let me add another thing. Please go ahead. Another thing we noticed too. So there was one clinic also in a village. Maternal mortality rate was high, right? So one time we sent an ambulance, and when the woman came, the baby had died. She had fistula. She had rectal vaginal fistula. Then the question was, and then it became more permanent in that area, very common in that area. And wonder, okay, there was a clinic there, but why were they not going to the clinic? They refused. Females, can you imagine? The female were not going to the clinic. Wow. So you have to understand Africa, there's certain things, it's about the words, you have to be careful when you impose it. They will fight it back. So we have to sit with the community. We went there as advisor in the health, the county health to went there, and we met with the chief, we met with some fund people. Why the females not going? You know why? Because of their religious belief. The guy at the clinic was a male, and it's a taboo in Islam for another man to see your wife. And they told us straight, until you bring woman to that clinic, they told us, it's a woman not going there, waste your time. You see that? They said, nope. You can do what you want to do. We would prefer death than send our women to that clinic. You got to change it. So we needed it. We sat down, we changed the guy, brought him back, and carry a female. Once we carry the female, the women start coming to the clinic. You have to understand, it's not just look at African countries. You have to sit with the community, understand the community. You don't have to work in so intensely that I've been to all 13 countries. I travel to all 13, and I understand each country is different. You have to understand the culture, the complexity. Before you start saying, I'm going to introduce this, change it, forget it. They will not go. If it's in contract, if the contract vein that religious belief, they will prefer death. I'm serious. They're going to that clinic. You got to sit with the community.
Yeah. I mean, this is an eye-opener. This is a rich interview with you, Dr. Paasewe. I knew of a situation where the main hospital was built, in a city, but what they did was that they had this system in place whereby they had nurses that worked in the hospital, even sometimes doctors, that would take the hospital jeep and drive certain days of the week into remote villages, to be able to meet people there. So like, for example, everybody knew on Wednesday, this village 1 hour away would have, these workers there. If you're sick, you can't meet them. The Thursday, another team will go to further, So again, you're looking at different strategies, because if you're talking about people walking 3 hours to the nearest clinic,
Yeah.
So one of the things that government could do also, we're talking about policies here, is that, they could institute a policy whereby, most of these, build a major hospital in a city, somewhere in the rural area, will understand that. But they have enough workers there, that you can allocate I'm talking about just starting from somewhere, you can allocate, okay, on Mondays, you will have a team of 5 taking the hospital van, hospital jeep, and will serve village 3 hours, 1 hour away. Tuesday, another team will go in another direction, serve the other village. And also, but then again, you talk about the infrastructure again, the roads. You have to have, government have to build roads to reach the villages,
Exactly.
that the hospital vehicle will be able to reach those people and provide the services, So healthcare, yes, I mean, just hearing you, it takes a lot, that's a lot more into healthcare than just say building a major hospital in the city.
It's different, yeah. And for example, even the rural disadvantaged communities, now the problem sometimes, you want to pay nurses that work in Monrovia the same money, for example, in the urban area, the same amount you pay healthcare workers that work in the rural area. So what is my incentive for working in the rural area if you're going to pay me the same? I am working in the disadvantaged community. Sometimes those workers have to leave their children in Monrovia with their mom and go and provide services. Now, the owner there until they find a job in Monrovia, you see, because you pay me off the same money. But if we can look again policy, so if you go to a rural disadvantaged community, we give you X amount of dollars, we pay your tuition, we do. So it is so complicated that we need to sit down at a round table and say, and you have to tailor make it. You can't one jacket fit, or it cannot work. We need to sit with each county and begin to design the health needs, taking into consideration cultural practices and religious practices, and how do we overcome those barriers?
Yeah. I got a question here coming in for you, Doc. It says, let me just scroll up to get it clear. Okay. How do we ensure proper use of resources? For example, medicines, financial, and all these supplies. How can we ensure that these resources are properly used, that are allocated for the healthcare sector is properly used for that sector. I mean, now again, that's going a little bit beyond your league now, because you're dealing with the ground. We
But
talk
no,
about
let me
policies,
address it.
about policymakers, right, and
Yeah,
bureaucracy and things like
but
that.
underlying that, we have to address poverty. Look at the hospitals in America. How many times people will steal like tissue or certain things? The blood pressure machine is there. Nobody take it because people can afford. I'm telling you, until we address right now, you put a blood pressure machine in a clinic. I guarantee you, after 3 months, it's gone. It's gone until you like it or it's gone because poverty. The janitor there makes $10 and or $50 a month. He sees a blood pressure machine that's $200. He's tempted to steal that machine. So the underlying thing is that if I should answer that question, it's poverty reduction. Then the next thing will be policy. Okay? Then proper incentivizing the healthcare workers such that they know that, hey, I'm making this amount of money. If I misallocate these resources, I'm going to lose my benefits. I'm going to lose all the benefits. So you know what? I'll choose not to do it. But in the absence of that, we have a long way to go.
Yeah, I think you with the question, I mean, it's not impossible, to ensure the proper use of the resources, right? Because you have the medicines being supplied, you have, money's being supplied, and allocation made for these public health sectors, and I think it's. I mean, can government do anything else to ensure that the money for the health sector gets to the health sector and is used for the health sector? I mean, is there a way that allocation we can ensure that it is done for the health sector?
Good. And another thing, good allocation. In terms of allocation, government need to seriously look at the budgetary allocation. In most countries in Africa, healthcare can one of the lowest allocation. So the government needs to look at the budgetary allocation for healthcare if it must grow. Yeah, the government can do so much, right? Again, it comes to incentivizing the people, right? Let me tell you one thing. If people have to choose between their benefits, if the benefits outweigh, what they need, what they want to do with the resources, they will always take what is the benefit. If it's over, but if you're paying a man what you call chicken change, and the man is in possession of all this money, like the accountant for the county, right? This man makes like $200, and this man is managing, like $200,000 a month. Tell me, man will not see. He has no benefits, no other benefits, no health benefits, nothing. It's just what we have. The underscoring all this in Africa is poverty reduction. It cannot be overemphasized. I'm not saying we'll get there over years, but we can do it in collaboration with other things. But we have to begin to address this issue. And that equity in wealth, equity in distribution, but it starts with us seriously looking at the minimum wage. Then government must invest in healthcare. They must invest in healthcare. And we should, it's good to collaborate with WHO and other international and global organizations. But those organizations, they are looking at how much are your government invested in healthcare. Now, if you're investing a lot, yes, then you have donors willing to come. But if you, the government, you make a minimum donation or minimum investment in healthcare,
it will not be encouraging. Yeah, it will not be encouraging. I got another question here for you. This one is talking about different pandemics that hit the world. And we know for Africa, the most common one was the Ebola that really ransacked Africa, especially the Western area. The question says, is there anything that can be done, or what can be done, to avoid another pandemic like Ebola? I mean, can we if the sector is not even built first, is there anything we can do, to avoid these pandemics?
Okay, so one thing is, you see, the thing Ebola for Liberia at that time was really, it have never happened before for Ebola, right? Look, okay, like Lassa fever, we know that, okay, this season we have Lassa fever. And that way we can create a public awareness, get rid of the rodents, get rid of this. We can intensify. Mostly Lassa fever outbreak was mainly in Banga area, right? And so then you can then take public health thing and intensify, getting rid of the rodent, get them rodent medications, getting rid of where rats live and whatnot, right? But the Ebola, it came from nowhere. It was not honestly, it's not common to Liberia. So it took the healthcare completely unaware. It's just like when you have snow in Georgia, 1 inch, they don't work because it's not part of that disaster preparedness, right? When doing disaster preparedness, you look at those disasters that are common to your state and you prepare for them. So likewise in healthcare. So if we're expecting during the rain season, there'll be the outbreak of this fever, then we can begin to intensify. But Ebola was totally, it came from nowhere. We don't up and down, I don't know where it came from right now. It's not common to West Africa, it's most common to East Africa. And the guys are already equipped with that. They know how to handle Ebola. They know how to contain it, and because they expect it, they give it an awareness because it's something that is very common to them. You know, so Ebola is not, but another answer is that they already have developed the vaccine that is now really effective against Ebola. So I think the government, you know, making efforts to keep that as part of the, you know, disaster preparedness.
I want, you know, before we conclude tonight, I want you to talk a little bit about, because again, we're looking at policies, you know, helping government come along with policies that would benefit, you know, African communities. Talk a little bit to us about your view on the whole idea of, you know, what we talk about sustainability, you know, just something like the CDC. You know, I look at Western countries and it seems as if each of these countries has a department specifically dealing with infectious disease.
Mhm.
You know, I mean, you look at all of them, especially when they rise of COVID, you see all these countries, the infectious disease department in America called CDC, National Health Institute as well. But each country in Europe and around the world, you know, developed countries, I noticed they have these built up sectors only for infectious disease. What do you think about something like that African government begin to look at? I know it ties right to investing, I understand that. But more specifically, building our own infectious disease, you know, bureaus or centers, you know, that specifically look at infectious disease specific to those regions. What do you think about that?
That would be the way to go, honestly, if health departments can. But what they can do, as when I was part of the disease surveillance for West Africa, that was the beginning. It's not necessarily it's not as complex as, you know, the infectious disease department, but what disease surveillance committee do, and the goal was to establish it at the local level, at the village level. So when Ebola started, the first case, the disease surveillance team would alert. There's an alert system. Oh, there's an outbreak here. There's an outbreak of measles. There's an outbreak of this. What we need to do. So yes, so as we work on developing an infectious disease control unit in Africa, which will be the really way to go, we can start with setting up disease surveillance teams at the very local level, at the village level. You know, start with that, and then we can, while we work on, you know, because it requires manpower, it requires people, a lot of people infection. And the thing is that, you know, we have to really look at the healthcare from Africa got a lot of experts outside Africa. You know, we need to sit down as Africans and say, okay, how do we bring these people back? What will it take? You know, how can we incentivize you guys to come for 1 year, you know, and train and do the with Africa to sit down and have a conversation. Also in the sub-region, we can share expertise, right? There are certain expertise that is in Ghana that Liberia can use, and there's expertise in Liberia that Ghana can use. So we need to sit down and share the expertise that is available in the sub-region. And if not, then we'll go to the bigger Africa. But I think there's a need to start on the local level, and as we develop the more complex structure in place.
You know, I will also, you know, just sound the alarm here, you know, because one of the things, you know, with Afri is, you know, again, we are policy solution driven organization. But I think just to, you know, tie with what you just said, it just came to my heart that you know, we need a major data center. You know,
yes,
like what you talking about, the surveillance team collecting all these data. We need a centralized system, so to speak, that all these data from the different sub-regions of Africa can be brought there to show the different outbreaks, the different common diseases in this area, and then an infectious disease, you know, control, you know, facility, or, you know, build that will study these data, you know, and then start, because I don't know many African countries that have a pharmaceutical company that produces their own medicine. Like in the West, you know what I mean? So our sectors have so many layers that we lack.
And you know, you really need the nail on the head when you said data quality. Let me tell you, when we're working in bombing, that is a problem we have, because most time decisions are made based on data analysis, then you do an action, right? So your healthcare can be driven, data driven, which that's what happened. So okay, there's the trend, but you need data to say, this, and that is the problem. Let me tell you one thing. And if you talk to experts, that's the problem with many African countries, the quality of the data.
Yeah.
So there's no data to make an analysis. There's no data to take action and solve problem. But I think you really got it. What do we need to work on is that data quality. The data quality, it is measured. Thank you.
Well,
That's
Doc, we can go on and on. Unfortunately, we are against time, but I'm telling you, this has been so enriching. At some point in the future, we got to have you back, Doc. We got to have you back because there's just so much, I believe, on your heart concerning the health of our people. Yeah. We are even the mortality rate. We die younger. We die younger. I mean, people here in the West living 90, 80, 90 is common. Africa, I mean, if you hit 50, it's a miracle. A lot of our people die in the 30s and 40s, Yeah. So it's just a massive to sustain this thing, And I just want to give you give you the opportunity to share, your concluding thought before we close tonight. When you talk about addressing this thing with policymakers, what advice you want to give to African governments and policymakers? Where should they start? I mean, I know it's just so much you talk about that's important, but just they got to start from somewhere, So what would be your concluding thought to those who make policies in Africa?
One, we should make policy about investing in healthcare. The government must be determined to invest in healthcare. They got to invest. How? By allocating more funds to healthcare, right? Two, it has to be policy driven, policy and implementation. Many times in Africa, the problem is not, sometimes if it's policy is there, there's problem with implementation. So we need to get qualified people in position now make these policies, and then we have implementers to make sure that those policies are implemented. I think if we can really have those things, one, investing in healthcare. It can be a policy too, where we say as a policy, our GDP will do with GDP, right? We will allocate X number of dollars to healthcare. 10%, 15% goes to healthcare, right? And then we have policies about and implementation policy. Policies around accessibility, policies around quality of care, policies around affordability. And the last thing, data quality. No joke. What you said is straight the core of the problem that we have in Africa, the quality of the data. Honestly, I'll tell you one thing, when I in Burma, when the expert came, they were so frustrated they could not get data. Because in the absence of data, you cannot present a case. You need data to present a case. So this is the trend in my community. I need resources to take this action. Then you're going to show that based on your action, the trend is now, in decline. But in the absence of data, you cannot make a case. That is so important. Data quality. Thank you for that. That is very important.
Well, we're going to leave it there for now, Doc. Hopefully, we'll give you another invite. We'll have you to come back again at some time in the future to just elaborate a little bit more on this. But friends and those watching us, want to thank you again for your time being with us. Again, this is AfriH, and you want to just say this, we'll leave you with the motto of this organization: doing better by doing right. We believe Africa can do better in the healthcare sector if she simply does. Thank you all for your time. Have a good night. Thank you, Dr. Paasewe. Have a good night.